Good morning, everyone. I'm Hartford HealthCare's Tina Verona. We are coming to you live from Westfarms Mall this morning, where you can see we have some empty chairs for our Walk to Wellness, but we want to fill these chairs. We want to get folks back in to see our monthly series, Walk to Wellness, here at Westfarms Mall. This month, all of March, is Colorectal Cancer Awareness Month. So we are here today to talk to walkers, although we do have some empty seats, but we do have one gentleman that has made the trek to the mall this morning. I'm going to come over here and talk to Anthony. Anthony, how are you this morning?
Oh, I'm really well, thanks. Better than I deserve.
Wonderful. So, Anthony, you're here at Westfarms Mall to see Dr. Kristina Johnson and to hear her talk. It is Colorectal Cancer Awareness Month. What brought you into the mall to hear this today?
Well, before the pandemic shut everything down, I used to come to all these presentations, and I used to come early in the morning also to walk before the presentations. Now that everything is shut down, that's been missing for me, so I was jumped at the chance when I got the email saying that it was continuing.
And Anthony, you've been fully vaccinated, correct?
Yes, both the first and the second dose.
So you feel safe coming out now?
I do feel safe.
What did you miss about the Walk to Wellness series? You said you're an avid follower and you come to most all of the sessions. What did you miss about it?
Well, I missed, getting the information. Quite frankly, I have a healthcare background, and I also miss the intellectual stimulation of interacting with the doctors and the presenters.
So today is all about colorectal cancer. It is Colorectal Cancer Awareness Month. What are you hoping to learn today?
I'm hoping to, I've been retired for about 10 years, and I'm hoping that, I might see what the latest, the current information is.
Well, we thank you for coming out today. You're the one and only, so you get the A for effort today. We appreciate you coming out, and we're going to get to the talk in just a little bit, but I'm going to make my way over to Dr. Kristina Johnson. So, Anthony, thank you.
Thank you very much.
All right. So joining me now live is Dr. Kristina Johnson. She is a colorectal surgeon at Hartford Hospital, division chief for the colorectal surgery department at Hartford Hospital. Dr. Johnson, thank you for being here this morning.
Thank you for having me.
Sure. So I want to start off by talking about, we have Anthony here, so he's going to be listening to our discussion. I want to talk about the American Cancer Society's guidelines that have lowered the screening to age 45. Tell us a little bit about that and your thoughts.
Well, that's actually true. It used to be, for many years it was the age of 50. But we're realizing that we're seeing colorectal cancer appearing in younger and younger patients. They have since now reduced that screening to 45, feeling that we will really make a difference in deaths because of screening earlier.
What are you seeing in your practice? Are you actually seeing that trend?
I am. I've just discharged a patient who's 41 years old who has probably stage 3 colon cancer.
And now colon cancer, the symptoms don't always present right away, or they could just be just about anything. It could be a hemorrhoid. How do you know? How do you know when it's serious enough to see a doctor?
Well, that's why we do the screening, because we don't know. When it's in the early stages and when we can really make a difference and cure people, we don't know. So when it's more advanced is when patients start to get more symptoms. But some of the things that we look for is abdominal pain, bleeding, change in bowel habits, and those types of things.
Dr. Johnson, we've seen really across the board in cancer in general, breast cancer and colorectal cancer, we've seen that you always hear about a family history. But often, in many cases, you're not seeing that family history, that it just sort of comes out of nowhere. What are your thoughts on that?
That's exactly right. I mean, probably about 70 to 80% of the time it's what we call sporadic. So you don't get that warning that mom had it or dad had it, that kind of thing. We do have newer ways of figuring out some of the genetic linkages and what's going on, specifically some of the mutations, but we don't have that across the board. So just having this screening protocol starting at the age of 45 is the best way for us to make a difference.
And I want to talk about men. So we have Anthony here, and I love to see that he is a gentleman, because men don't often are proactive in their health, but Anthony's here bright and early, which I love to see that. Let's talk about men, and it sort of came to light with Patrick Bozeman, who recently died of cancer, and he was young and he was a man. So talk to me a little bit about that in terms of gender.
Well, I think it's interesting because Chadwick Boseman was very young. He is a media celebrity, so really kind of shone a light on this. I think women get screened and get a little bit better access to healthcare, or more access to healthcare, because of pregnancies and having children. And so because of that, you're in seeing an OBGYN on a regular basis, whereas men don't have that, especially when they're young. So a lot of times it's really difficult to get men in just for routine screening, whether it's colon cancer, prostate cancer, or or high blood pressure, any of those types of things.
Yeah, you're right. Chadwick's death did actually mark and shine a spotlight on the need for screening. People are always worried about screening, and I think there's a stigma that comes along with it, that they don't like the prep or the actual screening. Take us through that entire process and what to expect.
Well, for screening with a colonoscopy, you do need to do a bowel prep. And what that means is you drink some medications that will help clean out the colon. Now, I've had many people tell me it's the lightest and the freshest they've ever felt when they get all cleaned out. Now, it is a day of having to have that kind of purging, if you will. When you come in, you do get the anesthesia. It's a great sleep. It doesn't have any of those nasty side effects of feeling yucky and bleary-eyed and stuff like that afterwards. So people tolerate the anesthesia very well. And then we get to know right away if there's any problems. And the additional fact is, when we do a colonoscopy, we can treat you. So we can take off those polyps, especially if they're small enough, and get rid of it, and so you're done.
Now, when you find polyps, can those actually turn cancerous? How do you treat polyps?
Yeah,
discovered.
Yeah, that's what we think. There's many different types of polyps, but the precancerous ones, the ones we call adenomas, we do take out with doing the colonoscopy, especially if they are small enough, and we've eliminated that risk of them becoming a cancer.
Speaking of colonoscopies, we're getting a lot of questions coming in. We have folks, thank goodness they're watching us virtually. They're not here, but they're watching us virtually, so we appreciate that. One of the questions from one of the viewers, are there any alternatives to getting an annual colonoscopy?
Yeah, well, we don't recommend an annual colonoscopy unless you have certain risk factors. So as it is, a colonoscopy, if you have no risk factors, we do every 10 years. If you have a family history, then we recommend every 5 years, and then there's various reasons to do it more frequently, history of polyps, some genetic disorders and things like that. So we usually don't even do an annual colonoscopy. There are other types of tests that you can get, some of the genetic markers that you can get, the Cologuard as an example. You can sometimes do checking for blood in the stool. The thing about all of those is if they are positive, you really have to get the definitive test of a colonoscopy. And with the colonoscopy, we can cure and get rid of the polyps if we see them.
I know you touched briefly upon symptoms, but obviously blood in the stool is of main concern, which could be hemorrhoids, but it may not be. But that is a telltale sign that you should be seeing your doctor.
Absolutely. So if you're seeing blood when you didn't have it before, definitely get it evaluated. It might be something as easy as a hemorrhoid, and that would be great, and we can actually fix that in the office. But you want to make sure that you get, if you haven't had a colonoscopy or haven't had any screening done recently, you really should get in.
Lots of questions coming in. Another one from our viewer. Will losing weight help decrease my risk of colon cancer? That's a good question.
That's a great question. I wish I could give you a definitive answer. We do know that there is an increased risk with obesity, but we don't have that literature far enough out to say that if you lose 20 pounds, that it will make a difference. So that's still ongoing studies right now.
What do you recommend for people that are now 45 and who might be on the cusp? What do you say to them concerning the American Cancer's guidelines that just came out?
Come in, get the colonoscopy. It's peace of mind, So then if you have any issues, if you have some crampy abdominal pain or something happens, you're like, okay, I had my colonoscopy. That's all good.
Yeah, we touched upon this briefly, but another viewer question, and I think this is such a popular question, and I'm sure you hear it all the time from patients, but how do you prepare for a colonoscopy? And I think a lot of it is really getting in the right mindset, right?
Right. You do have to have somebody drive you back and forth, so that can be a little bit difficult, but you start your prep the afternoon of the day before and get cleaned out. So you really, if you are, working, which some people are working from home, but if you are working, you really are only going to lose about a day and a half, okay? You do need to have somebody drive you back and forth, but that's about it.
I think it's the mental part of preparing for the actual preparation and then the actual colonoscopy itself. After the colonoscopy is over, then do you get the results? What happens after?
You get the result right away. All right. I tell everybody, but because people have a little bit of sedation, we always write it out so they have it to take home with them. but you get the result right away. So it's really kind of gives you that peace of mind. And you go home and you sleep for the afternoon, and then the next day you're bright and bushy-tailed, ready to go.
All right, we have another question. Before a colonoscopy, can I just take a pill instead of drinking that liquid? And we always hear that liquid is not the most tasty.
Right. Well, the good thing is the liquid has no taste, the one that we use. So you can put that in any type of clear liquid you want, all right? Obviously non-alcoholic, and that will help clear everything out. So there's really no taste, and you can vary the types of liquids you do, like Gatorade for the first half, I don't know, apple juice for the second half, that kind of thing. There is no one pill. There are pills that you can take, but it is a set of 20 pills that you have to take because you really do need to clean everything out. So you can take pills. We're still trying to decide if the prep is as effective, but people can just take pills, but it's not just one pill. We're not that good yet.
It's always that magic pill everybody's looking for.
Exactly.
Talk to me about when you're actually performing the colonoscopy. Are you able to differentiate a polyp versus something that could be a potential lesion or tumor? Is it distinct, or would it require further testing?
It's usually pretty distinct. Now, there are some polyps that can have a malignant part of it, but we'll take those off. We take off all the polyps that we see. Usually if I see something like a malignancy or a cancer and it's large, then I'm not able to take it out safely, and I'll do a biopsy of it. But I know right away when I'm taking a look, when I'm there.
What causes polyps?
That's a good question. We think it's a multifactorial thing. So we think it's many things that cause polyps. We know that there's a genetic contribution. We think that some of it is diet, and we think that may be what's contributing to our younger population. Nitrosamines, sort of like barbecue, all those burnt kind of part of it. We know that there's an increased risk with animal fat. We know there's an increased risk with smoking. We're still trying to parse out that obesity risk, but we do know that there is an increased risk with that. And there's some new literature questioning diabetes.
Interesting. Another question, speaking of diabetes, I have type 2 diabetes. Is my risk for colon cancer higher? Great question.
That's what we're still early literature out there, but we are seeing a trend that it's higher. All right, but it's still very early in the game.
Preliminary. All right. We have another question. Are there certain foods that may reduce my risk of colon cancer?
Well, we do know that if you avoid the animal fats, so you are doing the high fiber, the vegetable, those kinds of things will definitely help things out. And I don't know if it's really that you can say the high fiber prevents you from getting colon cancer, but if you're eating that, then you're not eating as much of the animal fats.
And what is it about the animal fats, or you talked about the burnt barbecues, the carcinogens?
We think that there's a carcinogen component of it. I don't know the exact, molecular makeup of why that happens, but we do know that that's a very strong correlation.
Interesting fact. Okay, another question from one of our viewers watching us live. What are the differences between colon cancer, colorectal cancer, and rectal cancer? That is a great question.
Well, it's interesting. It's just a matter of location. Yeah. It's like that old real estate, location. Colorectal cancer is just really referring to both areas. Colon cancer and rectal cancer, it all depends on the location of the large bowel where it occurs. Rectal cancer has some unique challenges when we have to treat it, especially when it's advanced, because of the location, especially near the sphincter muscles. And so because of that, it is a little bit different of an entity, but it's the same cells, the same type of malignancy. It's just because of the location.
Dr. Johnson, I want to talk about treatments. Treatments have come a long way in colorectal cancer. Talk about some of the treatments, minimally invasive options that are available at Hartford Hospital.
Right. So it's very interesting. We have, when we're looking at a spectrum of polyps all the way to cancers, we have pre-cancerous polyps and things like that. Starting from the beginning, we can still do the polypectomy during a colonoscopy. The GI doctors have some advances with doing an endoscopic submucosal dissection, where they can do a very advanced procedure where they can take out these larger polyps that we were never able to take out safely endoscopically. Then you get to the point in time where you need surgery now. If we're not able to take it out with one of those ways, then we can do a surgical approach and take it out. Either robotically, laparoscopically, open. We have all different types of approaches to getting to that area.
Right. Go ahead.
No, and then I was going to say, and then when we're talking about now we've reached the cancer, because I want to kind of go through the spectrum. When you reach the cancer, it depends on the location, but sometimes we do pre-treatment options with what we call neoadjuvant treatment. So we use chemo and radiation ahead of time, especially in rectal cancer. But in colon cancer, sometimes we just need to get it out and then treat with chemo or radiation, depending on what we find.
And you know, when we talk about all of these methods and treatments, it's really not a one size fits all for any patient. It's all very individually based, and it's all multidisciplinary focused too. Is that there are a team of physicians and surgeons who are discussing the patient, which I think is important.
Yeah, that's exactly right. So we have a multidisciplinary conference that we have every week discussing our colon and rectal cancer patients. What's the best approach? We have pathology, we have radiology, we have oncology, we have the surgeons, we have the GI doctors. Kind of everybody is there discussing what is the best approach from what they can do and kind of making a decision about the best treatment options for those patients.
So vitally important when it comes to patient care and in terms of mapping out from diagnosis to treatment to recovery. And speaking of recovery, talk to us a little bit about recovery to some of these surgical options, whether it be minimally invasively or conventional method.
Well, at Hartford Hospital, we do what's called an ERAS protocol. We like to use our little terms. Enhanced recovery after surgery. So for some of our more minimally invasive approaches, like laparoscopic or robotically, we are able to get patients out in a couple of days, where it used to be as long as a week. I remember when I first started training 20 years ago, patients were in the hospital for about a week, sometimes 10 days. Now they're getting their bowel function back faster because of the smaller incisions, and they're able to get home pretty quick.
That's remarkable. Tremendous strides that have come a long way. We have another question from a viewer. What types of doctors will I need during colon cancer treatment? And you just alluded to some of them, but let's go over those again for our viewer.
Well, it depends on the stage of the person when they present. Colon cancer comes in 4 stages. We do a full workup to see what the stage is, and then we can assess what doctors who need to be involved with it. But we have a great staff, nurse navigators, who their whole job is mapping out for that patient who they need to see, where they need to go, arranging all the appointments. So you have one phone call to kind of get it all taken care of, because sometimes it can be too much with having to coordinate all those appointments.
Well, I was going to say a nurse navigator is definitely a role that should never be underestimated. That is a vital component to a patient's diagnosis, because it can be a frightening time, and not knowing where to go and having that navigator taking you through and sort of taking that weight off of you and navigating, I think, is such a huge component. We have another question from a viewer. With COVID-19, is it safe to get my annual colonoscopy?
Well, I've been asked that question quite a bit. Everyone is tested before they come in. Every staff member is screened, and most of them are vaccinated now. So really, when I get asked by my family, I think the safest place to be is in the hospital. It's safer than going to the grocery store. Everyone's tested, everyone's wearing masks, everyone's keeping their distance. Everything is cleaned. So like I said, it's safer than going to the grocery store nowadays.
Absolutely. The safety measures and the protocols that are in place are incredible. And you're right, it is safer to be in the hospital. So we do encourage folks to come to the hospital, that it is safe. What's your final message in terms of anybody out there watching us right now? What do you want to say to them?
Well, I think the important part is to remember that with colon cancer, we can catch it when it's a polyp. We can catch it and get it out of your body and make it so you just don't even get to that point of having colon cancer. And this is one of the few screening tools that we have of all the organ systems that can do that. So you come in, you have that day and a half, you need to have somebody drive you back and forth, but you're done. And it's just an amazing thing we're able to do for people.
It really is. It's truly remarkable, because early detection is key. And what is the percentage in terms of early detection, catching it early? What are your chances? What are the percentages?
Well, if you've got it before it's a cancer, you're not going to have a problem. But if we catch it in stage 1, you have an 80 to 90% chance of cure.
Tremendous odds. Dr. Kristina Johnson, Division Lead for Colorectal Surgery at the Department of Hartford Hospital. We thank you for your time this morning and all the great work that you do. So for more information, you can go to hartfordhospital.org/colonoscopy. So these cancer guidelines have changed from 50 to 45. So we encourage you, if you are in that age group, to get your colonoscopy. Thank you so much, as always, for watching. I'm Hartford HealthCare's Tina Verona. We hope to see you back here at the mall next month to fill those seats. We'll see you again soon. For now, be well.